Once again, hello and welcome. You are here joining us at the Elsevier live webinar, Cancer Care During COVID-19 Pandemic and After. My name is Natasha. I'm with Elsevier and I will be your host for today. Before we begin, I would like to just go over some housekeeping rules. This webinar is being recorded and an on-demand version of this webinar will be available on our World Cancer Day website. A link to the on-demand version will be sent to all registrants. So if your friends and colleagues were not able to join, or if they would like to watch the webinar later, they can always watch the on-demand version. This webinar is being recorded in the Zoom webinar format. We would encourage all attendees to have as many questions as you would like. Please share your questions using the Q&A box at the bottom of your screen. And finally, we would love to hear your feedback. At the end of this session, there will be a feedback link and a QR code. Please do leave your feedback at the end of the session. I must say we have a very interesting session lined up for you today. It gives me great honor to invite our panelists. Sorry. So I'd like to invite our panelists today, Dr. Valerie Yang. Dr. Valerie is an associate consultant in the Division of Medical Oncology in the National Cancer Center, Singapore, and principal investigator at the Institute of Molecular and Cell Biology at A*STAR. Dr. Yang received the National Science Scholarship Dr. Valerie received the National Science Scholarship to read medicine and PhD from A*STAR. She graduated from the Royal Free University College Medical School with a distinction in preclinical medicine and first-class honors for a Bachelor in Science in Molecular Medicine. Dr. Yang received her medical degree and PhD from the University of Cambridge MB PhD program. Her PhD was supervised by Dr. Michael Gonzalez and Professor Ronald Lasky, where she studied DNA replication, cell cycle regulation, and embryonic stem cell pluripotency. Dr. Yang underwent residency training in internal medicine in Singapore and was accepted in the membership of the Royal College of Physicians, UK. She then received specialty training in medical oncology at the National Cancer Center, Singapore. She is now accredited as a specialist in medical oncology and a fellow of the Academy of Medicine of Singapore. Her research focuses on therapeutic vulnerabilities and resistance mechanisms, patient models, and the immune microenvironment in sarcomas and melanomas. She's also a fellow of the 2020 ESCO Ventures XA A*STAR Morphosis Program in Biotechnology Venture Creation. Thank you very much for joining us today, Dr. Valerie.
Hi, Natasha. Thank you. Thanks for the very kind introduction. And hello to everyone who's joining us today. And a special hello also to Dr. Hanen, my fellow speaker. Hi, Dr. Hanen. Natasha, would you like me to just start?
Sorry, Dr. Valerie, at this point, I would also like to invite Dr. Hanen.
Yes.
Dr. Hanen is joining us from Amsterdam. Dr. John B. Hanen is the Chief Scientific Officer, Immunotherapy, Consultant Medical Oncologist of the Division of Medical Oncology, and Staff Scientist in the Division of Immunology at the Netherlands Cancer Institute in Amsterdam. He's also the Professor for Translational Immunotherapy of Cancer at Leiden University Medical Center, the Netherlands. Dr. Hanen received his medical degree from the University of Leiden, then completed a PhD on human CD4 helper T cells at the Department of Immunohematology and the Blood Bank of the Leiden University Medical Center and the DNAX Research Institute in California. He then trained in internal medicine at Leiden University Medical Center and at Bronovo Hospital in The Hague. He did a postdoctoral fellowship in tumor immunology at the Division of Immunology, followed by training in medical oncology at the Netherlands Cancer Institute. His research focuses on the translation of novel immunotherapy strategies into clinical practice, especially adoptive cell transfer programs, immune checkpoint blockade, and biomarker research. His clinical medical oncology practice is focused on melanoma and renal carcinoma patients. Dr. Hanen is a co-founder of the Amsterdam Biotherapeutics Unit and was chairman of the Dutch Tumor Immunology Working Party for Oncology for many years. He's currently ESMO Faculty Chair for Immunotherapy of Cancer. He's the editor-in-chief of the ESMO journal IOTech. He serves on various national and international scientific advisory boards and committees, including the editorial board for Current Oncology Reports, Kidney Cancer, and ESMO Open. We are very pleased to have you here with us, Dr. Hanen. Thank you so much for joining.
Thank you very much for the kind invitation, and it's a great pleasure to be here. And also would like to say hello to all the people who are listening, and of course to Dr. Valerie, with whom I will be doing this webinar.
Thank you, Dr. Hanen. So I'm just going to quickly introduce our topic for today. COVID-19 is not a temporary glitch or a phase. It is a reality that is likely to persist in the long run. The disease has disrupted many existing healthcare practices, but it's particularly more important in the area of oncology. This is because, firstly, cancer patients are highly susceptible to COVID-19 and represent a really high-risk group. And we've also noticed it's been reported that the disease progression in cancer is more aggressive, and cancer patients are at a higher risk of death as well. Secondly, the high-quality oncology care requires a complex multidisciplinary approach, which makes it increasingly difficult. As a result, continuing oncology care while ensuring patient safety faced with unique challenges during COVID-19. And today we would like Dr. Valerie and Dr. Hanen to cover their perspectives, their experiences on how their institutions managed oncology patients during COVID-19. Dr. Valerie, over to you.
Okay, thanks very much, Natasha. And thank you again, everyone, for coming and joining in our session. I'm going to just share my slides. So give me a moment, bear with me. All right, can you see this?
Yes.
Yeah, okay. Okay, so thanks, Natasha, for the very kind introduction, and thank you everybody for joining us from all over the world. And I really look forward to hearing from Dr. Hanen as well, to really see how the situation in Singapore differs from the situation in the Netherlands, and we'll hear some exciting news from him as well later on. So I've titled the talk "COVID-19 and Cancer: Disruptive Change for a Better Future," because as Natasha has already mentioned before, this whole situation has truly been an unprecedented change in the way healthcare for cancer patients and all patients actually is delivered. And my heart really goes out to anybody here and any members of the audience who've been affected by COVID-19, either yourselves or people close to you. But I think perhaps let's use this session to share our experience and also discuss how we can actually capitalize on these changes that we're forced to have to adapt to, and actually how some of these changes can further improve how cancer care can be delivered in the future. All right, so bear with me. So what I'm going to do over the next 10-15 minutes is a very quick overview. So I think it's important to first of all, let me contrast what the situation is like in Singapore versus the Netherlands, because I think a lot of how we deliver care is really context dependent. And I'm also going to just share with you very quickly what some of the transformations in oncology in Singapore has been. And lastly, what does the future hold? So if we look at, so this I got from data from the WHO just a couple of days ago. And you can see that the situation in Singapore is quite different from the situation in the Netherlands. And I just want to also highlight the fact that the scale bars here are a little bit different. So here is 1,500, 1,500, and here we have 10,000. So you can see in Singapore, since the start of the pandemic, there have been about nearly 60,000 cases and 29 deaths. And the situation in the Netherlands is higher. And, of course, the population size in the Netherlands is higher as well. But you can see that over time, Singapore has been fairly fortunate in that recently there hasn't been a huge resurgence. But in the Netherlands, I think they're really facing the brunt of the pandemic now. So it'll be really nice to see, what Dr. Hanen has to say with regards to how the Netherlands has adapted to this. And I'm sure it's really, really not easy. All right. So I'll just share with you a little bit about what happened in Singapore. So as you know, the first confirmed case happened in Singapore late January, 24th of January. So this slide really shows what Singapore has been using. There's this system where they call the Disease Outbreak Response System Condition, summarized as DORSCON, which is actually a scheme that's imposed by the government. And I think part of this was developed during the time of SARS, which hit Singapore in 2003. So there was a little bit of a sense of if there were to be an infective disease that were to occur, what can possibly happen. So I think on the 7th of February, the DORSCON level in Singapore was raised from yellow to orange because there were a few more cases with unclear origins of COVID-19 that had surfaced. And actually from April to June 2020, while Singapore remained in DORSCON orange, we never escalated to DORSCON red. There was a circuit breaker that was imposed, much like a lockdown, from the months of April to June. So all non-essential workplaces were closed, schools were moved to home-based learnings, and most services were shut, including all food establishments. And I think only takeaway and delivery services were allowed. So where we are today is that we have finished the circuit breaker. We have had a safe reopening from the 2nd of June 2020 when cases were at much lower levels. And these reopenings were also conducted in phases. So there's phase 1, phase 2, phase 3, and as summarized here in a pictorial format, is really a graded kind of extension of the resumption of services in a safe manner. And so far, fingers crossed, there hasn't been a huge resurgence, but of course, we always have to be very, very aware and watch for any potential new resurgences that take place. So I'm going to share with you over the next few minutes what we at the National Cancer Center have had to do during the starts of the imposition of DORSCON orange. So during the time when, COVID-19 first appeared, I think everybody was scrambling, not just us, probably everybody around the world. We weren't exactly sure what to expect. However, we did know that there was a very real threat of a novel virus that is potentially life-threatening and highly, highly contagious as well. So what did we have to do? We really scrambled to really think about how can we minimize the transmission of COVID-19 while at the same time delivering optimal cancer care in our cancer center. So this, I won't go into all the details, but I'll just briefly summarize what we have done, and details can be referred to the paper. And I'm sure many other cancer centers around the world have also shared their experience. So briefly, we broke it down into screening procedures, what we did for outpatient clinics, how we were going to maintain continuity of optimal cancer care, as well as some of the peripheral activities, including multidisciplinary tumor boards, teaching of residents and trainees, as well as research. So in terms of screening, thankfully, I think numbers were not that high in Singapore, and there was adequate personal protective equipment for staff as per WHO criteria. There was always an infectious disease consultant who was available over the phone for any consultations as to queries as to how patients should be managed or whether a patient is to be highly suspected of COVID-19 or not. COVID-19 swabs were taken as necessary, and there was a very, very strong effort with the entire team set up for very stringent contact tracing for any positive patients. And this table here shows the Ministry of Health's suspect case definition, and also what would fulfill what they call the swab and send home criteria. So not every suspected case was admitted, for example. Those who were suspected but were able to, stay home, they would fulfill this criteria. We would swab them, they would go home and stay home, and they would stay home until a result was available to say that they were negative, and then they could leave their homes, as well as our own internal screening criteria as well. And you'll see that actually over the period of time, during the time when this paper was written, there had been about 801 visits and actually only one positive patient. And, frankly, I don't think this is credit to necessarily the procedures that the center had in place, but perhaps credit to the overall low number of cases in Singapore as a country as a whole. In terms of outpatient clinics, so with the imposition of DORSCON orange, it was made quite clear that the government's recommendations were we needed to reduce all non-essential visits and also to maintain strict physical distancing at our center. So what we did as an entire department was every physician actually went through their patient lists and went through all of their patients to decide which patients did not require urgent appointments, and all non-urgent appointments were deferred. And through this process alone, the number of patients coming to the outpatient clinics was already cut by 50%. And all patients and staff, of course, were wearing surgical masks at all times. There was a very strict policy to say no accompanying visitors as well. We had also set up a cohort clinic to say that individuals who were of moderate risk for COVID-19 would nevertheless be allowed to enter, but in a special cohort clinic where there was additional safety precautions. There was a maximum of 10 patients per clinic so that we didn't have too much contact with other people within the center. And of course, remote registration, and to minimize the amount of time spent in the center, patients would leave once the consultation was done. Billing and prescriptions were all electronic. We would also deliver medications to their homes for free, so as to minimize waiting times in the center. In terms of trying to continue optimal cancer care, I think we were also particularly concerned about our staff. So what were to happen if, for example, many members of staff had been infected, and would that not compromise, the manpower availability to care for our cancer patients? So what we had also done was we had split our entire department into smaller teams, and the idea was that each of these teams would not interact with each other. So you don't get a sudden outbreak of, the entire department of doctors and nurses are down, or infected, and you have a very difficult situation like that. So what happened was each small teams were covered areas of the ward geographically. So there was no crossover and no physical contact between the various teams. There was also a dedicated acute respiratory illness ward where any patient who had any sign of respiratory illness, whether it's COVID-19 or not, were specifically seen in these dedicated ARI wards, where within those wards, there were also stricter measures in place with clear distancing between patients and between healthcare staff who would visit these patients. Teleconferencing, of course, featured very highly in terms of conducting outpatient consults as well. And we tried to keep hospital stays to a minimum. So for example, the surgical oncologists, they activated an enhanced recovery after surgery protocol, and they also encouraged same-day admission for surgery rather than having a patient pre-admitted and staying overnight for a day or two before surgery. In terms of the peripheral activities, so multidisciplinary tumor boards, teaching and research, again, teleconferencing and virtual case discussions really came to the fore for us in this situation. We actually found that we could do this more effectively through Zoom and various other platforms. We could have the radiologist presenting their imaging findings, the pathologist showing the visual representations of histology, and it was well, I would say perhaps even conducted more efficiently than we used to conduct it previously, where all of us would gather in a room, which obviously couldn't happen with the onset of COVID-19. And I think a lot of people have also fed back that with regards to these tumor boards as well as teaching, more people could attend because it was even more convenient to attend tumor boards, and more busy residents could also attend teaching sessions virtually. So this was a plus to us. And at the time when COVID-19 was at its peak in Singapore, research and recruiting for trials was also put on hold. But the majority of now, all those have actually been resumed, of course, with physical distancing in place. So I just wanted to share with you next. That's just a brief overview of what we did at our center. What we also did at our center was, I think each of our teams, we came up with plans within each tumor type as to how we could reduce patient exposure to the healthcare setting while continuing optimal cancer care. So this slide is just a quick overview to share with you one of the disease entities that we looked at. And this was a poster that we presented at ESMO Asia, which is, we shared how we managed DLBCL, diffuse large B-cell lymphomas, in the COVID-19 era. So I'll just share with you this one because I think most of us would probably realize that there's some data from systematic analysis and systematic review and meta-analysis that among cancer patients, some cancer patients are thought to have, be more susceptible and more vulnerable to COVID-19. And that includes patients with hematological malignancies. And a very common entity is DLBCL as well. So DLBCL in and of itself is an aggressive malignancy, which also requires prompt and intensive treatment. So what we did was we tried to, again, here minimize the risk of COVID-19 while maintaining optimal treatment for these patients at our center. So what we as a team decided to do was, of course, reduce and defer surveillance consults, increase the use of telemedicine, unnecessary inpatient chemotherapy was avoided, and we tried to use subcutaneous administration of rituximab, which is a key component of treatment in DLBCL, as opposed to an IV administration, which would typically require a few hours of infusion. Subcutaneous administration only requires 7 minutes. And in terms of adaptations to DLBCL management itself, we felt that we should not compromise early and intensive treatment as required. And one aspect of DLBCL management is really to assess how likely a patient who at upfront diagnosis does not have brain disease is likely to develop brain disease. There's this idea that there might be value in giving prophylactic intravenous methotrexate to prevent the development of brain disease, which portends a very poor outcome in DLBCL. So to triage this, we used the CNS IPI score very strictly to decide who should and should not receive prophylactic intravenous methotrexate. We also made sure that patients received mid-cycle blood tests and prophylactic GCSF as well as prophylactic antimicrobials, because as most of you know, in the entity of DLBCL, a lot of patients are already in and of themselves already immunosuppressed, and with the institution of treatment, they might be immunosuppressed even more. So in terms of outcomes, thankfully, there were no COVID-19 cases amongst all the DLBCL patients treated at the National Cancer Center, and there was a significant decrease in surveillance visits as well. We managed to cut the total number of patients coming in. And unfortunately, majority of patients still received intravenous rituximab instead of subcutaneous, because a lot of them, this was actually the first administration. So it needed to be given intravenously to make sure that there's no anaphylactic reaction before we could switch to subcutaneous. And fit patients received curative treatment with no delay, and high-risk patients were given the more high-risk treatment approach with a more dose-intense protocol as well, with no clear decrease in the use of this regimen. So in other words, we were equally aggressive in the treatment of our patients during this time. Patients at high risk of central nervous system relapsed. The vast majority received their first dose intrathecally, and then later on, they also received intravenous methotrexate, but this was deferred to later cycles. And almost all our patients received prophylactic GCSF, mid-cycle blood tests, as well as antimicrobial prophylaxis. So we just shared this to also share our experience to say that perhaps this seems to be a fairly effective approach, and we don't know how the situation of COVID-19 is going to evolve, or even with future pandemics in the future, whether this potentially might be a good way to manage DLBCL. So the next thing I wanted to say is that actually now that, we've had the COVID-19 pandemic for a good year or so, if we think about numbers, and I just want to take us back to look at the big picture. Actually, in the past year, COVID-19 took about 2 million lives around the world and 29 lives in Singapore. But in that very same time period, cancer itself took more than 9 million lives around the world and more than 6,000 lives in Singapore. So what I really want to say is that I think this hits home, the picture, which is that we cannot compromise optimal cancer care. And I think optimal cancer care needs to be adapted to the new normal. So I just want to share this slide as well, which this and many other publications have suggested that the impact of delayed cancer treatments, for individual patients must be weighed against the risk of exposure to the virus, as well as, of course, institutional limitations in treatment capacity during the pandemic. The mortality due to cancer treatment delay is real. I think this particular publication shows you that with every 4-week delay in treatment, there might be additional deaths due to a delay of treatment with regards to the major cancers. So I think in this study, it was a systematic review and meta-analysis of patients of all ages across the major cancer types. They looked at published studies on a lot of patients, and you will see here that effectively the hazard ratios for death goes up with every 4-week delay to essential treatment. So I think, while the risk of COVID-19 is very real, we also have to balance that with optimal cancer treatment and management. So I also just wanted to share this, which I think is a great and free actually tool to use. This tool was developed by the University of Michigan. And what it does is you can actually access it on their website, and it's developed to help clinicians estimate the risk of delayed surgical or chemotherapy treatment, systemic treatment for individual patients for non-hematologic cancers. So I think they use very large separate data sets from the National Cancer Database to estimate the impact of treatment delay by cancer type as well as stage. So I think this is a very handy and nifty little tool, and it can be adjusted to your individual setting. So they will ask you to put in details like your R0 values, what the prevalence of COVID-19 is in your area, and that helps you come up with a little bit of a weighing in the balance of which should take precedence. What is the risk of getting COVID-19 versus what is the risk of delaying treatment? So I think that also helps us to better discuss with our patients what the optimal management of their cancer should be in light of the situation. And yes.
Thanks for sharing that. Since we're talking about optimal cancer patients and weighing in the risks while deciding treatment options, I think I'd like Dr. John Hanen to weigh in as well. Dr. John Hanen, can we have your perspective as well? Maybe you can share a little bit about what is the current COVID situation in the Netherlands, and then based on that, what approaches have you taken in treating the cancer patients, as well as what are some of the new things that you are now experimenting with that you would like to talk with us today?
Thank you. Yes, of course, I would like to do this. First of all, thank you, Dr. Valerie, for this very nice overview of what happened in Singapore, what your institution has been doing. And I think what happened in the Netherlands is probably a very good representation of what happened in Europe in general, with, of course, some differences here and there because of differences in healthcare systems. So when in February, the first patient was admitted to the hospital with COVID-19 disease, I think we underestimated the power of this virus. But a month later, the Netherlands was in what we called an intelligent lockdown. A outbreak management team was formed that advised the government on what to do, and that led to say very strict rules and regulations. Like I said, it was a lockdown for a couple of months in order to bring down the number of patients that were admitted, that were flooding the hospitals and were admitted to the intensive cares. And that led to the problem that many of the normal treatments, including cancer treatments, could not be given and needed to be postponed. And that was already something that also Dr. Valerie alluded to, that postponing a cancer patient's treatment may lead to more deaths at later time points, right? And so everything was in fact direct in order to bring down the number of admissions and therefore also the number of transmissions of the virus within the population. And it was quite successful in the beginning, so that in June, July, the rules, the regulations could be, let's say, tempered a bit. So could be some loser, and everybody was, of course, happy about that. But that came back with a vengeance, of course, because the virus in the colder months really came back with a second surge, and that led to a second lockdown in December. And in January, even a curfew in order to bring down the numbers. And what you could see in the slide from Dr. Valerie was that we are now entering the third wave of coronavirus infections in the Netherlands, and we have now over 1 million people that have been tested positive and had this disease. So it's really a severe problem, not only for the patients and the hospitals, and about 15,000 people have died from the disease, but also in many other ways. So for the elderly people who are isolated and socially not able to communicate, but also the young people not being able to go to school. So also the education is different from that used to be, and especially adolescents and teenagers are suffering a lot from this pandemic, and especially the lockdown that we are in. So in general, for the whole population, this is really a very difficult situation with a lot of negative impact. Especially for cancer patients, what we have seen over the past year is that cancer patients, of course, were already very afraid of getting the disease. They already had cancer, and having on top of that the COVID-19 would have been very, very dangerous for them. So even more than the general population, they went into what we call social isolation. And that has helped them, I think. On the other hand, also isolated them a lot. In the hospitals, the patient visits were changed very rapidly to video consulting and telephone calls, which of course helped. Is different. I think we learned that this is also a good way of dealing with patients. At the Netherlands Cancer Center, where I'm working, we are a dedicated cancer center. We tried to, in collaboration with also surrounding hospitals in Amsterdam, to have the least COVID-19 patients, so at least cancer care could continue normally. Remember that in the beginning of the pandemic, no one of us knew whether treatment with targeted agents, with immunotherapy or chemotherapy would make the disease for the patient worse. So we were afraid of giving these treatments. These treatments were also postponed for a while, until we understood, based on registries that were very rapidly designed and made by the national boards, but also internationally. Think of the CCC19, of the Peripheral registries. Also, as had a registry, and the UK had a big registry. So from that information, we learned that's probably safe to give all these treatments. But there are certain vulnerable patients more than others, and especially patients with hematologic malignancies are the ones that are extremely vulnerable and have a much higher chance of developing a severe course of COVID-19 and may die from that. And the same is true also for lung cancer patients that are in need of chemotherapy, but also because of the diseases often affecting the lungs, they are also at risk, and also for metastatic cancer patients, because all of these patients have a lower immune defenses, and because of that, they are more vulnerable to this disease. We have learned a lot over the years, and we are very happy that what we can see now is that the vaccination strategy seems to work. We know the results from Israel, where a large part of the population has already been vaccinated. And we can see now there the start of, let's say, fewer patients admitted to the hospitals, fewer patients dying from COVID-19, having severe COVID-19. So it seems that the vaccination strategy is working as soon as you have reached a certain number of vaccination level. And that is a very positive aspect, and everybody's looking forward to having hopefully a better summer coming with less of the restrictions that we are living in right now. Now, one of the problems with the vaccination, I will share my screen soon with you, is that in all the vaccination trials that have been performed up to date, cancer patients, especially patients that are actively treated for their cancers, have not been participating.
That's right.
And so we have very little knowledge about what the vaccination does to these patients, whether these patients are at the same level protected later on against a severe COVID-19 disease as, let's say, individuals without cancer.
Yep.
And in order to address that question, and we'll share my screen now with you. Let me see whether I can see.
Thanks, Dr. Hanen. Yeah, I
prepares the
completely
screen.
agree. Yeah.
Yeah, sorry, exactly. Dr. Valerie, I know you had some thoughts on the vaccine part. Why don't you share that with us?
Yeah, no, I think I'll let Dr. Hanen show his wonderful slides. Well, I'm really excited to hear more about his trial as well. Yeah, but I echo what Dr. Hanen says in that, you know, at the start of the whole situation, a lot of us weren't quite sure what to expect. So, you know, it's completely understandable. Us and various places around the world, we, you know, I think in the UK as well, a lot of the screening efforts were held off, you know, in the hope that when the situation settles a bit more, that it could resume. So I think in hindsight, perhaps that wasn't so good to do, but, you know, we have to learn from hindsight. I guess nobody would have known. And so now I think many places around the world, we're also grappling with the resumption of some of these treatments, resumption of screening, and dealing with patients who are diagnosed at a later stage of disease as well. Yeah, Dr. Hanen, over to you.
Yeah, so hopefully you can see my slide. So yes, I think that is a good point, right? Testing patients of individuals with either symptoms or even now without symptoms is also extremely important to find the individuals that are positive and could spread the virus. Of course, that containment of these individuals has been extremely important. But I think we must expect more of the vaccination. And like I said, we know very little about vaccination of cancer patients against COVID. So what we developed in the Netherlands already in the summer, we started working on that, is what we call the VOICE trial. VOICE stands for Vaccination Against COVID in Cancer, which is a study that's a multi-institutional, it's a multi-cohort prospective longitudinal study with the rationale that the risk of adverse outcome of COVID-19 is of course determined by the underlying disease and treatments. And of course we know that elderly individuals with comorbidities, obesity, but also diabetes or cardiovascular disease are at risk, but also cancer patients, as I mentioned before, are at a high risk. So I think that vaccination of these individuals against this virus needs to be prioritized, right? And immunotherapy and chemotherapy may impact on the ability to develop an effective immune response and even could increase the risk of adverse events, something we don't know at the moment. So if you look at the phase 3 studies that have been performed with the BioNTech Pfizer vaccine, Moderna vaccine, AstraZeneca vaccine, again, we have very little knowledge about certain disease groups like the cancer patients because they were not present in these trials, as shown here for the different studies that have been performed. And you can see that cancer patients were not included. So our objective is to assess the immune response and adverse events after administration of one of the approved COVID-19 vaccines in cancer patients treated with immunotherapy or chemotherapy, or the combination, the latter, of course, mostly in lung cancer patients. It's a prospective longitudinal multicenter multi-cohort study with 4 cohorts. One is a control cohort because we thought it was important to have a cohort in the study that is very similar to the patients in terms of age and exposure. So these are the partners of patients that are being treated in the cohorts with cancer patients. So that's cohort A, and then we have 3 cohorts of patients that treated with either immunotherapy, with chemotherapy, or the combination. These are the main inclusion criteria of this the study, which are typical for this kind of vaccination studies. So see also that the patients that have an active hematologic malignancies are not included at the moment. There will be a separate study being performed in that particular patient population, and as you know, these patients are more at risk than any other. So blood will be drawn at 4 time points, and participants will be vaccinated against the COVID-19 according to standard of care. And we will be using the Moderna vaccine. That was something that we learned this week. And in fact, the vaccination will start today in the Netherlands, so that the first patients will be vaccinated today and within the next couple of days and weeks. With the first vaccine, and then 4 weeks later with the second vaccine. And here you see the trial design, where we take also blood, and just to see the let's say whether the leukocyte count and other parameters are just in general, but we also take blood and plasma to look at antibody levels, of course, but also allowing us to measure T-cell responses against the virus. And of course, we have one before treatment and of course after treatment. And we measure at day 28 after the second vaccination the antibody levels, and that will be the primary objective, whether patients will have mounted a good B-cell response against the vaccine, and hopefully we will be able to translate that into what that level is good enough for protection against a severe COVID-19 infection. Of course, we will also gather the adverse events directly in the first week after the vaccination, but also immune-related adverse events in those individuals that are receiving immunotherapy. And we also look for 1 year at adverse events of specific interest, for instance, like Guillain-Barré syndrome, but also other severe problems that may occur or may be associated to this to a vaccination. So these are the primary endpoints, as already mentioned. So I think that this study will give us very soon an idea about how cancer patients in general do following vaccination, whether they are protected. We are going to prospectively follow them and see whether they will have a COVID-19 disease. But we will also try to disseminate the results as soon as possible, so that every individual in the world and every country in the world can learn from this. Suppose that patients that have been vaccinated, at least a subgroup of these patients, will have a much poorer immune response against the vaccine. Do these patients require a third vaccination, or do we have to install other measurements for these individuals? These are, of course, results that could be important for everybody working with these with cancer patients, right? So that is, I think, very important. The study has been published this week in Nature Medicine as a correspondence. And if you look at the supplementary data, the whole trial design is added, so other countries can use that in order to build their own study. For instance, it would be interesting to know whether the same results are being received if you use another vaccine than Moderna, for instance, the AstraZeneca vaccine or the Johnson & Johnson vaccine, that will be coming soon as well. So with that, I would like to stop my presentation, and I'm sure there will be many questions.
Indeed, Dr. Hanen, there are so many questions over here. First and foremost, thank you, Dr. Valerie and Dr. Hanen, for sharing your thoughts and such important details that you have both shared with us today. There are a lot of questions in the Q&A box, and some of them are actually very clinical questions. So what would be very interesting is that why not we get a perspective from both Dr. Hanen and Dr. Valerie on some of these clinical questions. It'll help to share both your experiences. For example, the first question is, does COVID show increased symptoms in cancer patients? So maybe more severe symptoms in cancer patients. If yes, then how do we manage this, and how do we stop the spread with cancer and COVID? So maybe we start with Dr. Valerie sharing her experience briefly, and then Dr. Hanen sharing his experience if you've seen increased symptoms of COVID in cancer patients.
Yeah, I think based on what's already been published, systematic reviews and meta-analysis, as well as some of our own work, which is just accepted for publication, which is, yes, it is indeed true that I think in general, cancer patients are thought to be more susceptible to more severe COVID-19. But what is also true is that we now know as well that within groups of cancer patients, perhaps some are more susceptible than others. So I think across the board, comorbidities such as, age more than 65, diabetes. I think some studies have also shown a male sex, you might
Yes.
get worse COVID-19 severity and cancer as a whole. But I think it's also true that within all of cancer, not all cancers are the same. There will be subsets of cancer type, stage, those undergoing specific treatments that are even more susceptible than others. Whether they have, how is this going to be managed? I guess in Singapore, my personal experience, I only have had one cancer patient who had very severe COVID-19, and he died from that actually. But he was a metastatic gastric cancer case who was he was actually bed bound at the time because he had spinal cord involvement. But he was, other than that, quite well. He had no respiratory symptoms whatsoever. But when he was diagnosed to have COVID-19, he went downhill very quickly. So within a matter of days. But that was my single experience. And as you know, in Singapore, we don't have that many cases. So I wonder if Dr. Hanen has, clinical examples of his own where do you find, Dr. Hanen, that in cancer patients who are found to be positive for COVID-19, do they deteriorate more quickly from COVID-19?
I think that in general, cancer patients do very similar compared to patients without cancer. But as you mentioned, there are certain subgroups of cancer patients that do really worse, right? And I think that the hematological malignancies is a very clear example, because these patients, because of their disease, already have a lower immune defenses. And then based on the treatment that they get, for instance, the rituximab treatments, where there are very few B cells around, of course, that also contributes to the poorer outcome, poor defenses that they have against the virus. Also, individuals that undergo stem cell transplantation, allogeneic or autologous stem cell transplantations, have, because of the high dose chemotherapy, already a much lower immune response compared to other patients with cancer. So I don't think you can say that for all cancer patients they have a higher susceptibility or a worse cause of COVID-19, but there are within the cancer population certain subgroups that are really at high risk. And as you mentioned, and we have also experienced in that, patients with metastatic disease and patients with lung cancer and also patients with hematologic malignancies are the worst. So what can we do about that? Yes, I think that in principle, what we try to do is give patients the treatment that they require for their cancer. As you mentioned already, there are more patients dying from cancer than from COVID-19. That's, I think, still all over the world. And so we have to try to give the patients their treatment that they need in order to bring down the mortality of the cancer. So we should not postpone treatments. I don't think there's any reason to do that. But of course, we have to tell patients that they have to be very careful, right? And usually cancer patients are extremely careful in that respect. And we should vaccinate the cancer patients. In general, I think we can vaccinate all cancer patients, with the exception of those individuals that have undergone allogeneic or autologous stem cell transplantation, high dose chemotherapy, where perhaps the immune response is too low after the treatment for a couple of months. So perhaps we have to postpone it at least 3 to 6 months before they are able to mount a good immune response. So that is, I think, the way we can deal with these cancer patients. Do you agree?
Yeah, no, Dr. Hanen, I completely agree. And I think, to be honest, there are guidelines out there, from NCCN and from ESMO, which addresses some of these specific concerns, So like if a patient who has cancer requires immunotherapy for their cancer, but they have active COVID-19, Do you continue with the immunotherapy treatment or not? Do you delay it? So I think there are some guidelines out there, and not all of it is entirely clear. I think there are also some concerns with regards to the use of targeted TKI therapies, so the PI3K, AKT, mTOR pathways, the RAS, RAF, MEK kinase inhibitors as well are thought to be critical pathways involved in the immune response in
Sure. Yep.
perhaps the recovery from COVID-19. So I think, this is a very valid question to ask. And to be honest, I think we're all still kind of learning as we go along. And the way we've done it, at least for us, in that, we don't have that many cases, we always have an active discussion with the infectious disease specialist. Obviously there's a competition of priorities as well. So if a patient, has metastatic disease, but has very, very severe COVID-19, maybe the focus should really be on assisting with the, supportive care for COVID-19 first, because if that patient dies from COVID-19, then the cancer treatment becomes moot. So it's always very individual. And on the other hand, if you have a patient with metastatic disease or a very aggressive cancer who has very mild COVID-19, then perhaps we should crack on with the cancer treatments rather than postpone any of these things for theoretical loss of benefit, I think. Yeah,
Totally agree with you. Yes.
It depends on the situation and the individual,
Sure.
and of
Yeah.
course the availability of resources.
Absolutely. Yeah.
So there's a related question on what you guys were just discussing on whether to treat versus whether to cure the COVID first. The question is that chemotherapy is actually advisable in COVID patients in a moderate to severe stage. What sort of isolation facility is required for this type of a patient who's going through chemotherapy as well as COVID treatment? Also, can pain management cause contraindications in immunocompromised patient?
I think that for let's say the normal chemotherapies that we give to cancer patients, so the chemotherapy we give to breast cancer patients or colorectal cancer patients or prostate cancer patients, in general can be given without much problems. Of course, if patients have symptoms that could relate to COVID-19 infection, there should be a disease that they should be tested for that. And if that is the case, you may want to postpone the next treatment with chemotherapy until they have recovered. In general, I think that, like I already mentioned, cancer patients are extremely careful, and they know that they are more vulnerable to as a patient population in a whole. So what we usually advise is to really follow strictly the rules that have been set by the government, meaning keeping the distance, 1.5 meters, washing hands frequently, having very few visitors, and especially those that have symptoms, of course, keep them out of the house, use masks when you go out, things like that. And while doing that, I think that that limits the chances of these individuals attracting infection with the coronavirus is very limited. So if you really follow these rules strictly, I think these patients can be treated very efficiently.
Yeah.
And is that the same experience, Dr. Valerie?
Yeah. So I think the situation in Singapore is a little bit different in that because the cases are not that high in number. So any positive COVID-19 case in Singapore, I would imagine in a patient who is also undergoing treatment for their cancer, they would probably be admitted to the hospital and they would be kept in a single room with the necessary precautions as well. And they would be jointly managed by the infectious disease team as well as the medical oncology team. Only because I think, at the current moment, we have the resources to do so. The ICUs are not, packed to the brim. The case numbers are not that high. And that's why we have the luxury of being able to do that. But I suspect in many other countries around the world, there might not be this luxury. And it's really, dependent on what's available and what's not available. In Singapore, at the moment there's anyone who's positive, there's a whole team of contact tracers who finds out, where this came from, and everybody gets, kept in their homes and isolated. Certainly, if there's anyone who's on treatment for cancer, I suspect they would probably be monitored inpatient as well.
That's great. So we have time for one last question. There are many more in the Q&A box. And what we will do is we will try to share these questions with our panelists offline, and maybe they can answer them via email that we will share the responses. But for now, we'll just take one last question. What are your thoughts on the new variants of COVID-19, and how do you think it can affect cancer patients? Dr. Valerie, do you want to share your thoughts first?
Well, I think it's a difficult one. We will see how things evolve. I think, again, it's a situation where we don't have very much information yet about how things are going to evolve. And I think, the understanding is that the current vaccines should work for some of these new variants as well. But there may be a time where we don't know whether new variants might not be targetable by the current vaccines. But having said that, the new paradigm for mRNA-based vaccinations are also quite beneficial in the sense that it can be rapidly designed to target new variants. So the hope is that, if there really is a significant new variant that isn't, in a sense, preventable by current vaccines, that we can quickly develop one to adapt to that. That's my overall take. I think generally we should. I'm quite hopeful for the future. Let's put it that way. Yeah,
and Dr. Hanen, are you hopeful as well?
I am certainly hopeful, absolutely. I think we should continue with vaccinating as many patient individuals as possible very rapidly, right? And of course, there's the danger of having these new variants coming. In the Netherlands, we see that the UK variant is now the most common one already. Thank God, it's that the vaccine that we're using is also protective against this this virus, but there may be new ones like the South African, maybe the Brazilian one, that are less sensitive to the current vaccine. But the flexibility that Dr. Valerie was alluding to of the vaccination of the vaccine development is so good that it should be able to adjust to that. And remember that every year we have influenza, and every year we have to adjust the influenza vaccine to the type that we are probably going to be dealing with. So we are in fact used to that, and in the future I hope we will get to that same level as we have for influenza.
Wonderful. So with that, I'll go back to sharing my screen this time. First and foremost, thank you very much, Dr. Valerie and Dr. Hanen. As you can already see in the chat, this has been an extremely informative session. So thank you very much for sharing the information. I will do my tiny bit by sharing some additional resources that our audience can benefit from. So this was actually the ESMO guidelines paper, which Dr. Valerie referred me to. And it covers a lot of things at a high level that we touched upon in today's webinar. And I would encourage our readers, our webinar audience, to check out this paper. It's freely available. So please do go through this if you're interested. We're also organizing another webinar on the cancer patient journey next week at the same time. As you all know, this is the Elsevier Cancer Awareness Month in commemoration of World Cancer Day. So we will have another webinar on the topic of cancer patient journey. Please feel free to join us. You can scan the QR code to register. And also do visit our World Cancer Day website. On this website, we have toolkits for 8 cancers that share information such as statistics, prevalence data, recent guidelines on 8 different types of cancer. So again, all those users who are interested, please do visit our World Cancer Day website as well. And then there are some additional resources on COVID-19 that you can have access to. We have the COVID-19 Healthcare Hub, as well as a number of resource centers. If you are into COVID-19 research, you can access a lot of free research on COVID-19 through these resource centers as well. And finally, thank you very much, audience. You've really been a great audience. Thank you so much for all your awesome questions. As mentioned, we will share your questions with our panelists today, and we will try to send you brief responses to your questions via email. Finally, thank you very much, Dr. Hanen. Thank you very much, Dr. Valerie. And thank you, our audience. Have a good evening. Bye-bye, and have a great weekend.
Thank you, Natasha. Thanks, Dr. Hanen.
Thank you.
And thank you,
Bye-bye.
everybody. Bye-bye.
Thank you.